This educational video has been developed by Guildford Vocational Training Scheme and is intended for GP registrars and their trainers. The case-based discussion, or CBD, is one of the required workplace-based assessments, and a trainee will need to do at least 24 of these during their training. Since these assessments are required, it's very understandable if they are seen simply as a series of hurdles to be navigated. The problem with hurdles is that they don't really get you anywhere, and perhaps a better analogy is to see CBDs as a series of steps, each one bringing you to a higher perspective. With the pace of general practice these days, it is rare that we have the chance to stop, slow down, and consider a case in detail. CBDs give us the opportunity to do just that. As doctors, when we talk about a case, certain aspects tend to dominate our discussion. We naturally like to talk about the data we've gathered and how we've interpreted it. We would always want to discuss the diagnosis we've made and how we've made our decisions. And clinical management is a natural area to focus on. Other aspects of a case, however, can easily be glossed over unless we give them special attention. For instance, have we really considered all the holistic dimensions of the case? Have we thought about how teams have worked together and whether we might be able to improve the way teams communicate? And have we really delved into all the ethical challenges involved? What the CBD encourages us to do is to think outside of our usual default patterns of thinking, to avoid tunnel vision and broaden our outlook as we consider the care we give to our patients. An important concept to understand is that a CBD does not have to be limited to the actual case. It's a discussion based around the case, which means it can move far beyond what actually happened. It is not an assessment of what the trainee actually did, but an assessment of the trainee's ability to think broadly about the case they've seen. For instance, it may be that the case involves a patient with alcohol addiction. The discussion could move from the individual patient involved to a far more broad-ranging analysis of alcohol services in the locality, the strengths and weaknesses of the alcohol support which is available, how these might be improved, and the role of the GP within the bigger picture. In this way, the competencies of team working and community orientation will have been covered, and the trainee will have developed by engaging in a very high-level discussion. The next important principle is to use CBDs to develop the important ability to think broadly about our patients. This does not come naturally and requires practice. For instance, it's tempting to think of only certain cases having an ethical dimension, such as contraception in the under-16s or end-of-life decisions. However, if you're prepared to think broadly enough, it's hard to think of a case that does not have an ethical dimension. Let's take the case of an elderly patient with heart disease who's prescribed a statin. On the surface, this seems straightforward, but how do we know if statins do more harm than good in the elderly? Do we have enough evidence to make this judgment? The patient may be happy to take the tablet, but before we conclude that we've respected the patient's autonomy, have we actually enabled autonomy in this patient? In other words, have we given them the correct information in an understandable format to empower them to make a judgment? And if we were to decide not to prescribe a statin, could we justify this on the basis of age alone? Or would we be being unethical on the grounds of discrimination? By the end of the ST3 year, you will have gone through the process of case-based discussion 12 times. And if you can dissect the ethics of each CBD case to this level of detail, then you will achieve a high degree of proficiency in this important area of general practice. And so too with each of the 10 competencies covered by the case-based discussion. Finally, choose well and spend time in preparation. Choose a case with depth, one that troubled you or left you asking questions. Home visits often make good cases, or one where you've seen the patient several times and really got to know them. And spend some time in preparation. Go through the competencies in turn and see the case through each individual lens. What were the holistic aspects of this case? How did I make my decisions? How could I improve this patient's computer record? How does the community context affect this problem? The best discussions arise when both trainee and trainer have done some groundwork, ideally writing a paragraph or two under each competency heading. Then the conversation can reach a much higher level and tap into the richest themes of learning. Thank you for listening.